Hello, you. Welcome back. This is Sophie Kim speaking. Today we're here to talk about ventilation, and you're watching Disney. You're watching KSSK CMD chats. Today we're here to talk about ventilation. Hi, Kierra.
Hi, Sophie. I actually wanted to ask, I personally have had a BiPAP for, it's been like over a year at least though. And I wanted to ask what your experience is with the BiPAP.
I've had a BiPAP for 3 to 4 years, I want to say. No, when I got one, I realized I really did need one. At first it was kind of annoying because the mask on your face and whatever, I'm like, I can't move. And then I got used to it, and now I'm way less tired during the day and I sleep way better at night. So I'm really glad I got one. When I first got one, I got the mouth and nose, so it's the full face thing. I don't know, I felt like it was a little bit uncomfortable, so I decided to try the nose pillows or whatever, the things that go like that, you know?
Yeah.
And I find that more comfortable personally. I use that now.
I personally use the full face one.
Yeah.
It looks kind of like something you would see Air Force pilot wear, like the triangle type thing. My favorite thing about it, besides the fact that it helps me breathe, is that if I'm lying in bed and I'm holding my phone and I drop my phone, it won't hit my face. It hits the mask instead. And
Yeah.
It's so nice.
That's funny.
Ever since I actually first got it, it's made it easier for me to know when I need the settings changed. I notice, wait, I'm having headaches, or I'm feeling tired.
Yeah.
I should probably talk to my pulmonologist.
Oh, also, I recently got a sip and puff. It's just, it's just the straw. This is the straw to my water, but it's just it's nice. It's not constantly going. You just when you sip on it, you get a breath. So I sometimes use that during the day if I'm just tired that day or something.
I'm very excited for our interview.
Yeah, and it's going to be helpful to other people who maybe don't have it yet or are deciding whether they should have it or not and don't know what the benefits or risks are. Now, let's go straight into the interviews. Hi, everyone. So we really appreciate you joining us today. You're going to teach us about ventilation in this episode. Could you please introduce yourselves?
I'm Rob Graham. I'm a Pediatric Intensive Care doc at Boston Children's Hospital. So I'm usually the guy you don't ever want to see. But I also run our home ventilator program here and have been involved caring and supporting children and young adults and families with neuromuscular disease for many years.
And I am Geovanny Perez. I go by Paco. I'm a pediatric pulmonologist. I was in DC for several years, and I just moved to Buffalo, New York, around 5 or 6 months ago. And I've been involved in the care of patients with neuromuscular disorders for probably 7 years now.
So in a previous episode, we learned that those with CMD who experience sleep-disordered breathing often begin using nighttime breathing support. So could you talk about the different types of interfaces and the importance of finding the right one?
So it's very, very, very important to find the right interface. Number one, you want to feel comfortable with the mask. And number two, you want to avoid any leaks with the mask. You have different types of masks in the market. Depending on the age group, you might find different types. You have masks that will cover just the nose. Some of the masks that will just go under the nose and push the nostrils. They are called nasal pillows. You also have masks that will cover the nose and the mouth. Sometimes you have to be careful when you're using masks that are covering the nose and the mouth, because the patient is not able to remove the mask by themselves. In a case that somebody vomits, there's a potential risk that the machine is going to push that fluid inside of your airways. But it's very important that you have a very good mask fitting. You probably should have maybe 1 or 2 different types of mask at your home, so you can alternate the mask depending on how do you feel, if there's any pressure points or areas that you might feel uncomfortable.
That was one of the main problems I got when I got my new BiPAP, because I have a crooked nose, so fitting the mask is really hard, especially because the one I'm the most comfortable with goes over both the nose and the mouth. So there were leaks for days until we found one that had the right cushion on it,
Right.
which helped make sure that it didn't leak.
I used to have a nose and mouth, but then I switched to the pillows, the nose pillows. It's more comfortable.
I wanted to ask if you could quickly explain what IPAP is and EPAP and something called backup rate. Would you mind explaining what all of that means and how the different settings on a machine is determined?
It's a great question. I mean, I guess it's actually first important to say it is important to have the BiPAP or bi-level and not just CPAP, really, for most people with congenital muscular dystrophy. The way I sort of think about it is CPAP is helpful if you just snore, if you've got something in your upper airway, large tonsils or, things like that. You hear about, someone else in your family who has a snoring problem. They may just use CPAP. But with the muscular dystrophy, we want to provide you with help to overcome anything up here, but really help with your breathing. And that's where the bi-level comes in. And you're right. A lot of these machines can be, they have a lot of bells and whistles. They can do a lot of different things. I think the easiest way is to think about it's bi-level. So there's an EPAP, expiratory positive airway pressure. That's just a constant level that gives you sort of, no matter what you do, it's going to give you a little bit of pressure to sort of keep open your upper airway and make it a little easier for you to take a breath. And then there's the IPAP, which is when you actually go to take that breath, and it gives you that boost. It's that inspiratory positive airway pressure, and actually helps you expand your lungs and expand your chest. And that's actually probably the most important part for someone with muscular dystrophy, is it helps us get rid of, opens the lungs and helps us get rid of the carbon dioxide and exchange with the oxygen. The rates, some of them, and it really depends on, each person in terms of what their specific needs are. We breathe less frequently when we sleep, put a backup rate in there, but, and when you're sick, it may be completely different. But some people, we have set rates. Like, I want to guarantee you get 10 breaths a minute. Others, we just let the machine have that backup if you don't. Everyone's a little bit different, but those are sort of the basic things when we think about it.
With someone with CMD, if we're trying to determine these settings, what do you look at to decide that?
So ideally, you should have a titration. That's kind of like the medical word to figure out how much pressure or backup rate you will need. And ideally, you should have that on the sleep lab. It will give us an idea of how we're doing with your CO2 levels. It's very important to try to have that pressure that it will allow you to have normal CO2 levels. In the sleep lab, we will be able to titrate some of those settings. So we might be able to increase that pressure. We might need to increase that backup rate. Sometimes the backup rate is important when some patients with CMDs, they might be weaker than others. So sometimes it's very hard to trigger. The machine needs to sense that you're breathing. And when the machine can now feel that you're taking a breath, then the machine just says, we're not gonna give you anything. So having that backup rate, it might give you, at least it will give you some kind of like rate during the night. So if for whatever reason you get weaker or something changes during your sleep, you're getting a set number of breaths every night. Now, you can also do some titrations at the bedside if you are either in the hospital or sometimes in one of the clinic visits. I don't know what devices you have, but I'm sure that some of your devices probably have that little card, an SD card within the device. Or like newer devices, actually, they have a modem attached to it. So you can send some information wirelessly to your doctor. The machine will give you some kind of information. It's not as good as the sleep study, but it might be helpful to maybe tweak the settings at the bedside. I will say that the sleep study is perhaps the most important part when you're dealing with, especially if you have problems, if you're having issues with your oxygen levels, if you're not sleeping comfortably and the next day you continue to have headaches or symptoms, I will say that the sleep study will be the next best step to figure out how you're gonna adjust those settings.
Funny that you mentioned the like download card, because I actually have both the card and the Bluetooth setting, which I heard makes it easier to check on like a daily basis.
I think that what I will be looking more is for trends. So I'm not sure if like a daily kind of like download might be that helpful, but if you take a look like maybe like every few days or every week, the machine can also give you like information about the leak. So you might see, oh, maybe the leak went from like these liters per minute or this percentage, and then suddenly something changed. So it's just kind of like pieces of a puzzle. So each piece is gonna be, or is at least gonna try to help you figure out what is going on.
Everything that we're doing with the BiPAPs are really to, hear a lot about carbon dioxide, because, everyone focuses on oxygen. We want to keep the oxygen levels in your blood high, but actually it's getting rid of the carbon dioxide, as Paco said, is what we really focus on, because if it's too high, that's why you get headaches, that's why you feel tired. It actually puts a bigger strain on your body in terms of, your heart has to work harder and other things. So that's why all these little tweaks we do with the BiPAP and why we look at the sleep studies as opposed to just how you're feeling during the day is to usually get rid of the carbon dioxide. And all those little things actually makes it easier for you to use the BiPAP. So the inspiratory time, the trigger, the rise, all of those are just fine tuning just to make it so that it's as comfortable as possible, so that you, when you go to trigger it, when you go to sort of take that breath, it doesn't come too fast or it's not too hard. I mean, that when you go to take that breath, it just, you feel resistance or otherwise. And so we want to give it so that it's comfortable enough when you want to take a breath. It gives you a breath long enough to expand your lungs, because if it's too quick, it doesn't get a full benefit. But we also have to give you time to exhale. And the humidification, it really depends on the person. We want to keep, your nose and mouth humidify your air normally, but if you're blowing air into it, you get dry. And so the humidification helps you from a comfort perspective as well and keeps your secretions and your lungs loose. Some people don't like it because to humidify air, you have to heat it up, whereas cold air just doesn't hold water much. So I have a lot of people your age who just say, I don't want the humidification anymore, and they just choose not to. So we work with you around that.
It's very tricky. I think that is very patient dependent. There are certain things that you can work with your either pulmonologist or whoever is helping you work with your BiPAP. I think that the ramp on your BiPAP is what it helps you to see how fast the pressure is delivered, and then you adjust the ramp to make it like go very fast or go slow over time. So if you imagine if you're like getting a lot of air at once, as soon as you fall asleep, it might be uncomfortable. So if we make it like go up little by little by little, then you might feel more comfortable. And everybody's different. I mean, some people might like it to have like a very quick ramp, so you go very quick, or sometimes it's very slow. The rise time is tricky. I mean, again, the rise time is to see how fast in time you're gonna get delivered that pressure. There are little tweaks. Everybody's a little bit different. Some of these settings can be changed even by yourself, like the humidification or sometimes the ramp, depending on the device. You can even tweak it yourself at home. Now, the humidification, the only thing is that you should have some kind of humidification. Obviously, without any humidification, then there is a problem, because then your nose is going to get dry. You might build up some boogers. You could potentially have some bleeding. I mean, remember that if your nose is very dry, I mean, especially you start like touching your nose, if it's itchy because you have dry secretions, you could potentially bleed from the nose. And remember, you're going to be using this device every single night. So sometimes it takes some time to get used to it. I'm sure that it happened to both of you. It wasn't just like, boom, this is awesome. It just takes some time to get used to the pressure, to maybe the type of air, either cold or warm when you're getting your humidification. But it's very important that you have some kind of humidification.
Going further, what exactly is an AVAP, and how does it differ from the BiPAP that we previously discussed?
They are like new kind of like settings. Some people would call it hybrid, or some people call it more like a smarter or smart settings. When Rob was mentioning about the pressures, remember he was explaining to you that you have like a lower pressure that will keep your airway open, and then you have a higher pressure, right? So that you're expanding your chest like this when you're breathing. That is mainly the goal of the bi-level of your BiPAP device. Now, these kind of like hybrid methods, what they will do is, especially the AVAPS, we're going to base a tidal volume. A tidal volume is the amount of air in cc's that you breathe in. So it varies by person, by age, and by size. So basically what the machine is going to do is once we figure out more or less what is the volume that you need, so then you set that into the machine. And then what the machine is going to do is going to play in the upper pressure. You're going to have two limits. So the machine can work in between two pressures to try to target that volume. It has some advantage into this, because remember that depending on the position that you're on the vent, or depending if you're sick or not, how your respiratory system works changes. So you might have, maybe your tongue is going on one side, maybe your lung is in a different position when you're on one side versus the other. So in between breath, or in between the positions at nighttime, what we call the compliance of the lung or the system is how easy it is to ventilate your lungs. It will change over time. So you have one pressure throughout the night, then you don't have room to maybe increase that pressure or decrease that pressure depending on how your lungs are working overnight. So with this AVAPS mode, then at least we can have that room where the machine is going to play between two upper pressure. And the other advantage is when you're sick, if you have a minor cold, I'm sure that you know what to do with all of your airway clearance devices. But again, if you have a little of extra boogers on your nose, you might need a bit of a higher pressure. So having this kind of like hybrid mode might be helpful when you have a cold or when you're recovering also from a cold, that the pressures will come down.
So we have BiPAPs, AVAPS. You mentioned CPAPs too. Are those similar to BiPAPs and AVAPS? Is it something that someone who has CMD could or even should use?
Yeah, for me, that's the most important takeaway from it, is that CPAP should not be used in people with muscular dystrophy. I mean, I think that's the key, is that it doesn't help you with that carbon dioxide clearance, but it doesn't help you with the assistance with your breathing, the chest expansion and things like that. And something when we work with families is that you really do want that bi-level. But for the most part, it's what you guys find comfortable, and then how you work with your docs to make sure it's doing what it should be doing.
One of the problems with these new names is that every company, every brand is going to label it a different way.
Right.
What we know for sure is that what is CPAP is CPAP, what is bi-level or BiPAP is BiPAP. And make sure that, yes, anytime it should be BiPAP, it should not be a CPAP. The other ones are just little tweaks, and it will depend on how comfortable you feel. It depends if it works for some people, for some other people it might not work. But they have different names depending on the name of the machine that you have. So that's what it makes things very complicated, from some pulmonologists or ICU doctors being more familiar with one brand and with one kind of setting. Mm-hmm. And in another part of the country, you might find out other people knowing the other brand and knowing those settings. At the end of the day, as long as we understand the principle and making sure that you're able to bring down the CO2 levels to normal levels, which is what we want, that's kind of the key thing. And all of the machines will follow the same basic principle.
What exactly is mouthpiece ventilation, and when would someone with CMD use it?
Mouthpiece ventilation, I mean, there's different names. I think that you probably heard at some point about the sip and puff ventilation. Mm-hmm. Is a ventilator attached to, it looks sometimes like a little scroll, like a mouthpiece. Basically what you will do, you will put your mouth there, you close your lips or purse your lips around that, and then the machine is going to sense there is a trigger. So the machine will sense that you're trying to take a breath, and the machine is just going to deliver some volume. And you can take it as many times as you want. You can do 2 or 3 breaths, one after another. That's called stacking breaths. And the indication is for somebody that is developing daytime respiratory symptoms. So if your oxygen levels are low when you're awake, or when your CO2 levels are a little bit high when you're awake, then most of the time we're trying to push for mouthpiece ventilation. This usually follows after you've been on BiPAP. So you will start first with nighttime ventilation, and it might follow to daytime ventilation. It's effective. It takes some time for some people to learn how to do it. It's not straightforward. If you think about it, right, if you have that little thing on your mouth and then all of the air goes into your cheeks and you're just doing this, right, it's not going to go into your lungs. Most of the air is going to go into your cheeks. Or sometimes you might have a leak around the mouth. So it takes some time. It takes some time to work with a good RT, so you learn how to use the mouthpiece.
That's what I thought. I have a sip and puff.
And the newer BiPAPs have that option, which is nice, because you need a BiPAP that has a battery, because presumably you're using that so you can get around and do your normal activities. So you want to, you don't want to be plugged in all the time. We used to have sip and puffs in some of the older ventilators that we had to just disable all the alarm, which was not a safe thing. But the newer devices actually make it easier, so it's portable.
Sometimes if I get tired or if I have a headache, I actually wear my mask and just lie down and just breathe with the mask. I wanted to ask if that is relatively okay, and if someone can still wear a mask for daytime ventilation instead of needing to use a sip and puff.
Absolutely. I mean, if you're having a bad day and you say, I've got a headache, or I'm just a little bit more tired or what have you, a lot of people just sort of pause and go on. And, it's not like you necessarily even have to, lay down and take a nap. You just, you're on the computer, you can wear it, do your normal thing. Some people like the sip and puff better just because it's not stuck on their face, and you can have it on demand. I mean, that's the nice part about the mouthpiece ventilation too, is that, you know, most of the time you sort of can connect it to a power chair or something else, or even just in a stand next to you and just kind of go to it when you need it, as opposed to having to take it on and off and having something on your face. So it's kind of a personal preference, and it also just depends on how often you need it.
So what we've been discussing is an NIV, which stands for non-invasive ventilation. But what if somebody decided to not go with that and instead have a tracheostomy? Am I pronouncing that right?
What?
When would somebody like choose a tracheostomy over a NIV?
For whatever reason, either preference or for any other reason, somebody might consider a tracheostomy. Through a surgical procedure, make a little hole in the neck, and then you put something called a tracheostomy tube that it looks similar to an endotracheal tube, but it goes through the neck. So the tracheostomy tube is something that a parent or a nurse will learn how to change it. And again, this is attached to the ventilator, and this is something that patients, they can go home with. So they can do something, they can live with this at home and they can use it.
I mean, there are lots of reasons people get tracheostomy tubes. A lot of people without muscular dystrophy have them for other reasons. I think that's helpful to know. The main reason, though, for someone with muscular dystrophy is they're reaching a point where they're not able to come off their non-invasive, or maybe they've had a severe pneumonia and it's really, you know, it's part of their recovery. Part of it is we're now very good at supporting people with BiPAP, with non-invasive. It's really challenging, because if you are starting to have daytime symptoms and aren't just relying on the sip and puff to help you feel a little better, but really need that, or, you know, you're using the non-invasive during the day more and more, the question is that safe? And are we actually doing what we should be doing? Are we helping you with your breathing enough? And so that's sort of when we reach that point where we're just like, should we talk about a tracheostomy? You know, it takes getting used to having something in your neck. They have problems with it. But you can still talk. I think that's one of the things that people don't realize. You can still talk with a tracheostomy tube. If you could eat before the tracheostomy tube, you could probably, it'll take a little adjustment, but you could probably eat afterwards. Yeah, it's never an easy decision. But we like to have those discussions before it's an emergency. I think that's the other thing. And I don't know if either of you use a cough assist, or if anyone, I mean, I know you've talked to other people about that. You can still use that through a tracheostomy tube. We do adjustments, because instead of, you know, blowing air in, you know, in your mouth and stuff like that, you're blowing it directly into the airway. So we sometimes have to lower it, actually, not use as high pressures.
Right, that makes sense. I do have a cough assist, so it's good to know.
Yeah, I have one too, and I was wondering, like, can you use a trach for everything, kind of?
Yeah, no, it's, I mean, it gives you, for good or bad, it gives you direct access down into your airway. So it's, in some respects, it's easier to get stuff out if you need it to.
So this has been super informative. Thank you so much. I learned a lot more about my own use of breathing support, and now I have some new things to think about for my future.
Yeah, thank you guys for taking your time to help teach us all that.
Yes, thank you so much for your time, guys.
It was a
Pleasure.
For more ways to stay connected, download the CMD mobile app and sign up for the newsletter. Here is a link to the CMD Pulmonary Guide, which is very interesting. And if you have questions, email us at breathe@curecmd.org. And wait, before you go, be sure to like and subscribe. Add your comments below to keep the conversation going. Thanks again for watching. Bye!